And welcome to Disparities Dialogue. I'm Bruce Oviagale, the president of the Society for Equity Neuroscience, and I'm happy to welcome you all to our January edition of Disparities Dialogue. This time, we're focused on pediatric epilepsy. We have a wonderful panel of experts in pediatric epilepsy who are going to guide us through some contemporary articles that have been published over the last 18 months. Delighted to introduce Dr. Sonal Bhatia, who is faculty at the University of Texas Southwestern, Dr. Christina Briscoe, who is faculty at Harvard University, and Dr. Pojomovsky-McDonnell, who is faculty at the Children's Hospital of Pennsylvania and the University of Pennsylvania. Welcome. So without further ado, we'll move right into our article showcase. We have 6 articles we'd like to discuss today. The very first article is a scoping review looking at health and healthcare disparities in pediatric epilepsy in the US. The next article focuses on health disparities in youth, but taking a close look at behavioral health outcomes. Our third article, very importantly, establishes common data elements regarding social determinants of health in pediatric epilepsy research. Our fourth article examines delays to care in infantile epileptic spasm syndrome, looking at the issues of racial and ethnic inequities. Our fifth article examines the issue of disparities in utilization of genetic testing for non-acquired infantile epileptic spasm syndrome in a single center in North Carolina. And last but by no means the least, our last article takes a look at building bridges for equity in epilepsy care. So we'll now move to each article. Our very first article focuses on health and healthcare disparities in pediatric epilepsy in the United States, was published in the journal Annals of Neurology in 2024. And Dr. Bhatia is going to kindly walk us through this one.
Thank you for this opportunity. I'll be speaking about this article that was published in Annals of Neurology in 2024. And this article was, so as to speak, the foundational article from the Pediatric Epilepsy Research Consortium Special Interest Group, the Health Equity Special Interest Group. So I'll speak about what is Pediatric Epilepsy Research Consortium. For those that are not familiar, it is currently a non-profit organization and has currently over more than 90 centers across the US with several pediatric epileptologists, neuropsychologists, neurosurgeons, many other folks involved in the care of children with epilepsy who also have a research interest. And the Pediatric Health Equity Special Interest Group was formed in June 2020. So just to give you a little background, initially the idea was put forth in December of 2019, but there wasn't a very robust response. So the idea was put to rest. And then between December 2019 to June 2020, there were lots of reports of crime against people of color from different parts of the United States. And so that kind of renowned another interest in looking at disparities and looking at outcomes for people of color and people from lower socioeconomic background, etc. So the special interest group was formed, and initially the special interest group provided a response to NINDS's request for information. The NINDS was soliciting data and looking at disparities and inequities in various neurological disorders across lifespan, and pediatric epilepsy was one of them. And the authors, and I wasn't a part of that initial response, but the other core members, Karen Shea, who's the first author, Janelle Wagner, and some other members were involved, and they drafted a response to NINDS. And found only 7 papers that focused on pediatric epilepsy and contained data that had disparities. And that wasn't enough. And so that sparked this whole idea of doing a scoping review to look at the length and the breadth of the existing data and identify knowledge gaps where it comes to disparities in the field of pediatric epilepsy. And we all know that this disparity related data is very, very important in understanding the overall outcomes of children that have seizures. So we started on this pursuit of doing a scoping review, and this was started around November 2020. So actually August 2020 is when we started doing, 2020 is when we started doing this. July 2020, we submitted the response to NINDS. And then by August 2020, we had started organizing our team and then started basically collecting the data, identifying the research terms, collecting the data. And by November 2020, from November 2020 onwards, the actual work began. So we basically searched peer-reviewed articles and gray literature only for studies that happened in the United States, or if there was a multi-country study, so say for instance, Australia or Europe, a part of it had to be done in the US for the study to be included. We adhere to the PRISMA guidelines, and we basically identified disparity populations and outcomes. So the disparity populations were also provided by the NINDS, and we expanded upon that. So we included measures such as sex, gender, gender identity, race, ethnicity, socioeconomic status, geography, education, language, immigration, to name a few. And then we identified a set of outcomes, and some of these outcomes were built upon by what the NINDS wanted folks to study, which included epilepsy prevalence, treatment, difficulties in getting care, etc. And so we kind of built our foundation with the NINDS outcomes, but then we added a whole bunch of outcomes. And all the authors that are on the paper, they discussed and came to a conclusion and then formulated additional outcomes. So we included epilepsy incidence, prevalence, access, utilization, adherence, side effects, mortality, SUDEP, economics, to name a few. And we decided that when we will be looking at these articles, we will define a finding from each publication as a single result that had a discrete statistical analysis which looked at a specific outcome by disparity population. So to give you an example, if the disparity outcome was SUDEP or mortality, we would be looking at the disparity populations, for example, gender. So we would say that would gender make a difference or affect the outcome when it specifically comes to SUDEP or mortality? So based on of this question, we looked at each disparity population and then looked at it from a disparity outcome standpoint. We obviously started off with about 13,000 plus papers and then narrowed it down to about 10,000 records. And we so basically screened over 10,000 abstracts, looked at the abstracts, looked at the title, and then decided if the abstract or the title contained words like pediatric epilepsy, disparity, gender, sex, race, ethnicity, outcomes, and basically out of the 10,396 papers that we initially looked at, we only included 307 publications, and there is more to come in the diagram in the next slide that I have. And out of those 307 publications that we selected, we then extracted data from those 307 publications, which were basically only from the US. Like I said earlier, it included at least pediatric data, so they had to have data from ages 0 to 21. We also included mixed data, so which means that the publications also included some adult data, but they still had to have pediatric data. Only English language studies were included, and we also looked at thesis, and we also looked at abstracts for this. We found 769 unique disparity and equity findings within those 307 publications. The vast majority of the findings were disparity findings, and the number is 769, like I said. We found that sex or gender was the most commonly reported disparity population in all these findings and in all these studies, and the second being race and ethnicity. Language and immigration, so a disparity population which included language or immigration related parameters was studied the least. When it comes to outcomes, we found that the vast majority of the disparity outcome in these studies focused on quality of life and neuropsychological outcomes. So whether it came to mental health issues in children who had epilepsy, whether it came to cognitive issues, family functioning, quality of life related outcomes. And we also found that the vast majority of these studies did not intend to investigate disparities as one of their objectives. So the vast majority of the studies, so more than half of the studies actually did not focus on the theme of the study was not to study disparities. It was they were studying something else, and they also had some disparity data within the study, but the focus of the study was really not to look at this a topic of disparities related to pediatric epilepsy outcomes. However, there were a few studies that actually intended to focus on looking for disparities, and obviously they did find that there was disparity. So they did find meaningful data when they were actually intending to look for it. But for the studies that had not looked at it, those studies basically were the vast majority. We found several limitations in the study. So first and foremost, limitations from the personal standpoint, from the author standpoint, the difficulties that we encounter, and then I'll talk about the limitations from the literature standpoint that we had. So from an authorship standpoint, I think we struggled. First of all, this was a very, very lengthy, time-consuming process. So it took us over 2 years to go through this entire process of screening the abstracts and then basically finding the articles and then basically making sure that all of us are in agreement that these are the number of articles that should be included, and then extracting the data and then analyzing the data and then finally putting this paper to publication. It took us a long, long time. So that was really a big component, of the struggle or the challenge that we had or also a lot of limitation because it was very time consuming. We also felt that when we were screening the articles, a lot of it was reviewer dependent. We did include reviewer pairs, so 2 reviewers looked at the same set of abstracts and voted, and we had a third person vote if there was basically conflict, but there was still a lot of it was subjective, and there was not a very good process of how we were screening the articles as well as how we were extracting data. So, for example, if the study included epilepsy surgery as an outcome and studied disparity populations, now epilepsy surgery could be divided into, say, maybe access as an outcome or utilization as an outcome. So which category does it go to? So a lot of that was also very much subjective and dependent upon the authors. So that was a little bit of a limitation that things were subjective, although we tried to have pairs, we tried to have a third person who would vote and be a tiebreaker. And then if that was also not possible, then we would bring this issue to the whole group and we would have our group discussions and then kind of basically categorize our data properly. And so those were the limitations. And then obviously, the good thing about going through this whole process was that we definitely saw that there is an improvement in the research in the last 10-15 years where we are seeing more and more articles related to pediatric epilepsy that are looking at disparities and inequities. So that was something that we concluded from our scoping review. So this slide over here shows the Prisma diagram on the left, which I kind of already talked about. We had over 13,000 initial articles or abstracts that we initially identified. we had removal of the duplicate records. So we had about 10,000 records that we screened, and then basically we excluded over 4,000 because, like I told you, either they were not US-based studies, or they did not include pediatric data, or there was no disparities data. So ultimately, out of the over 10,000 abstracts that we looked at, we found only 307 papers that actually contained meaningful data related to disparities and inequities in children. And the graph to my right talks about shows the number of publications that have improved over the last 50, 60 years on this topic. So if you see that before 1980, it was about only 20% of the publications really focused on this topic, and then the trend has really increased. And in the last sort of 10 to 15 years, we have more and more data on this topic. And that was also one of the things that we wanted to look at, is that did we have more disparities before, and do we have less disparities now? Have the times truly changed? And unfortunately, we really couldn't answer that question because of the huge variability that we had in the number of publications in the past and currently.
That's wonderful, a very important topic. And thank you so much, Sonal, for providing the background, the impetus for this study. I just want to invite Pam or Christina in case you have any additional comments or questions. Not at this time. One question I have is just, Sonal, in terms of directions this particular painstakingly done scoping review could provide to us in terms of future research considerations.
So like I was mentioning earlier, that when we were looking at the articles, we really did not find that the data was collected systematically. So that was one thing that I think this review can help us with future research, is to have some rules and regulations, if you will, to collect data systematically when it comes to disparities. And I know that our future research on common data elements, which Chris will be talking about, does try to address that lacuna on this topic. We also found that even when studies were focused on looking at disparities in pediatric epilepsies, sometimes the way the data was presented was not clear. So sometimes we would find some data in the abstract, sometimes we would not. Sometimes we would find data only in the results section, nowhere else in the paper. Sometimes we would find the data only in the table in the article, but again, there would be no other mention anywhere in the paper on, what does that mean? Sometimes there would be data in the table, but there would be no mention in the discussion or conclusion of what that data meant. So I think having that sort of standardization also would be helpful for future studies or researchers that are looking to focus on this topic, is how they are presenting the data in the paper, so that it's really easy for people like us who might do a scoping review again in the future to be able to grab that data really easily from the publications. So that was another challenge that we faced, is that the data was all over. So if the numbers were only in the table, we were like wondering, does this article need to be included or not? Like, what does this even mean? Sometimes we were left on our own to interpret the findings without the authors giving us any guidance on what that data actually meant, in their research. So I think two things stand out. One is how the data is organized in the publication, and most importantly, how the data itself is collected. Because like I discussed, that we had a large representation of gender as a disparity variable, but not so much language or immigration status. One could argue, and I remember arguing this with my group, I used to argue, I was like, why are we even considering gender as a variable? Because there are certain epilepsies that are more common in women compared to men. So is that really a disparity, or is that the natural course of the disease? Like, for example, Gibbon syndrome in children is more common in girls compared to boys. So is that a disparity, or is that just how nature has, made this basically? So I think we had some underrepresentation of variables as well. So making sure that we include variables that are not studied properly, or for instance, race was also sometimes just a binary variable. So whether it was just Caucasian versus non-Caucasian, or Caucasian versus African American, and race and ethnicity was sometimes not split into different components. And we know that race and ethnicity are two different pieces that can lead to different outcomes. So So I think what we understand is that better data collection and then a more more better way and more organized way of like actually presenting the data is what we learned from this paper.
No, thank you, Sonal. And clearly, as our audience can see from the figure on the slide, there's been gratifyingly an increase in the quantity of publications. But as you hear Dr. Bhatia mention, we need an improvement in the quality as well in terms of the reporting and organization as well. Okay, thank you for that. We'll move to the next paper, which was published in 2025 in Epilepsy and Behavior. And this takes a close look at behavioral health outcomes in health disparities in youth with epilepsy. And so again, Dr. Bhatia will kindly walk us through this one.
This should be very quick because this is essentially an offshoot of our scoping review paper. So like I mentioned earlier, for our scoping review paper, we found that behavioral health outcomes or health-related quality of life and neuropsychological outcomes were the most commonly studied or most largely represented in the literature from the scoping review that we looked at. So the scoping review's goal was to just sort of give you a 30,000-foot overview of what is there on this topic, and we did not get into the granularities of each and every outcome. Since behavioral health outcome was the most obvious and had the most number of findings, we decided to kind of give a deep dive specifically focusing on this outcome, and we utilized the data from the scoping review and we built upon the data. We did another search after we had completed our scoping review to just also look at more papers and more publications on this topic, and we built this paper based off of that. And we wanted to basically again explore disparities and inequities related to health-related quality of life, neuropsychological domains in children, and we divided them into 4 groups. So mental health related outcomes, neurocognitive outcomes, family functioning, and health-related quality of life. So to give you an example, mental health would include topics such as depression, anxiety, behavioral issues. Neurocognitive would include IQ measures in children who have epilepsy or difficult to control epilepsy. Family functioning would look at basically how does the family perceive the child's condition and if they have any issues with coping up with the child's epilepsy. And health-related quality of life is a very self-explanatory term where we are looking at how does the patient or the caregiver perceive their quality of life when they have a child with the chronic condition. So the original scoping review, out of the 309 publications that we had included, as you can see, the vast majority, so 85 publications, focused on this topic. We had 177 findings from 85 publications. The authors ultimately decided to exclude gender-related findings, and so the number came down to 42 papers and 76 findings. The group had initially thought of presenting gender-related data as a separate project, as a separate paper altogether. So that was the reason why gender-related findings were excluded. And then, like I said, we because our scoping review data was slightly old by the time this paper was being published, we did another literature search to identify new papers that were published since November of 2022. And this search was done in May 2024. And we found only additional 3 papers since that time, which we also included in this review that focus specifically on behavioral health outcomes. So out of the 76 findings, 62 were in children or had pediatric samples, and the remainder were mixed. So mental health domain obviously had the most papers and findings because there is a lot of data on depression, anxiety, behavioral issues in children with epilepsy. However, we found that there were more equity-related data in comparison to disparity-related data. In our papers, we define equity if the statistical value was not significant, and disparity if the statistical value of the analysis was significant. And the disparity variable that was most frequently reported across the behavioral health domain was socioeconomic status, followed by race and ethnicity, and then other smaller papers also included education and insurance. By far, we found that socioeconomic status had the most meaningful correlation with behavioral health outcomes in this paper, where it had a very strong correlation to mental health issues. So we found that children that had lower, the studies that were published showed that children who belong to a lower socioeconomic status reported higher rates of behavioral issues, anxiety, depression, and also having a low socioeconomic status equated directly to having a low health-related quality of life score. Coming to the limitations of this paper, so again, there were a lot of, and the next slide has the tables where we see that some of the domains like neurocognitive or family functioning have, very small representation, not many publications, distributed equally across. Like I said, mental health emerged the strongest in terms of the number of papers, but many other domains did not. Once again, we found the same issues that we had found with our scoping review, that the study, the way the study was done had very variable methodology. Once again, sometimes the findings would be in the abstract or in the results section or in the tables, but not in the discussion. So we found that the same issues that we essentially had found in the scoping review, because this paper was essentially an offshoot of the scoping review. We also found that there may have been a bias in how the sample was presented in the literature, because most of these children who have behavioral issues or health-related quality of life issues are the ones that tend to have refractory epilepsy. So we obviously may have oversampled those cases and really may not have sampled the entire breadth of patients suffering from pediatric epilepsy. So for example, what happens to parents, or how do they perceive their quality of life when a child has a first seizure or is newly diagnosed with epilepsy? I think, those studies may not have been included, whereas children that have refractory epilepsy or are surgical candidates are more likely to see a neuropsychologist, are more likely to report stress or poor health-related quality of life issues, or have issues in when it comes to their IQ, etc. So once again, I think this paper, while it's meaningful and gives a representation of how disparities can affect behavioral health outcomes in pediatric epilepsy, it gives you a good understanding of what is out there in the literature. I think we definitely cannot draw very many conclusions from this current paper, again, based off of the limitations that I discussed. So on this slide here, on my left is once again the schema for how we organized our data, and I already went through that. Like, based off of the original paper, we had findings, and then we added more, and then we removed some, and we came up with the 4 domains. And on the right, to my right, basically is the table that shows you the findings across the disparity findings across the 4 behavioral health domains. And we can see that in some of the disparity populations like insurance or education, you really some areas don't have any representation. There is not really any papers in that area. But if you look at socioeconomic status, like, that seems to be emerging as the most strongest variable when it comes to looking at behavioral health domains. So in the mental health category, as well as in the health-related quality of life category, the vast majority of the findings showed that in the literature, they showed that if you had a low socioeconomic status, you likely had more mental health issues if your child had epilepsy, and also a poor health-related quality of life score.
Well, thank you, Sonal. And if I may ask a question, so for our audience members who might be healthcare system leaders or healthcare system providers, aside from the systematic collection of social determinant of health variables, what other measures can be taken within the healthcare system to better investigate behavioral health outcomes in children with epilepsy?
So I think that you bring up a great question, and I think that also highlights certain issues that we face on a practical basis, from a clinical management standpoint, when we are looking at children who have epilepsy, and how do we better investigate and understand behavioral health issues in these children. So things that we could do perhaps is also basically have, like I said, this data was very biased because we only had perhaps refractory epilepsy cases, but having a universal screening, for children to look for behavioral health problems right at the outset, irrespective of who they are, where they come from, what their insurance is, how do they look like, what's their immigration status? That would be very, very helpful to give us, a better understanding of like the breadth of the problem across pediatric epilepsy. So that could be one of the steps. The second steps could be, again, having sensitivity from a language and cultural standpoint, both from the providers as well as other members of the healthcare team, such as social workers, or when it comes to counselors, psychologists, neuropsychologists, to be able to better understand these issues in the context of a child's ethnicity as well as their language. Because depending upon the culture or the ethnicity or the race or the country of origin, people may perceive epilepsy stigma that can be variable compared to, children who are born and raised in the US and come from a higher socioeconomic background. And those can also impact how they perform in many of these behavioral health domains, how they report depression or anxiety, how they report stress, how they report health-related quality of life questionnaires. So I think having that is very important. And I know Chris is doing some great work focusing on language sensitivity when it comes to, the different outcomes related to pediatric epilepsy, and how we can have better testing batteries also for children that are non-English speaking would also be helpful. That would give us more data as well. Right now, we are focusing more on English and Spanish, but there are other, languages that are spoken in the US. Patients that come to us that don't speak Spanish or English, but speak other languages, even though they are a small minority. But we should not forget about them. So having better ways of assessing those children will also help us in better understanding the depth of this problem and better investigate the depth of this problem.
Oh, thanks, Sonal. And my other question for you is, what about school? How can school be leveraged to address disparities related to neurocognitive and behavioral health issues in children with epilepsy?
That's a great question. You bring up a very good question and a very practical question. And I think once again, the things that I discussed earlier, the school obviously should incorporate that. But most importantly, the school, again, should be also focusing on addressing these outcomes. Also, so looking at if a child is diagnosed with pediatric epilepsy, or the child is diagnosed with epilepsy or has pediatric epilepsy, then the school system should definitely focus on giving them support to look at if they have depression, if they have anxiety, if they have behavioral problems, how are they perceiving stress, how is the family doing at home, what is their health-related quality of life. So the school should definitely be aware of that. I think the big component of addressing these domains in school is how a school handles a child's epilepsy and seizures. That, in my experience, is a huge issue. And I think that has repercussions when you talk about behavioral health domains. So, for example, if the child has a seizure and the school just calls the parent, hey, come pick up your child had a seizure, that, I think, causes the child to feel sort of isolated, or basically feel like, oh, I'm being singled out. And maybe my friends are asking me, why do you keep going home every single day? Like, what's wrong with you? So that causes lower self-esteem in the child. That causes more anxiety in the child. That also causes issues from the family side, because a lot of these things that I mentioned are happening in those schools where children that are coming from a lower socioeconomic strata study. These are the schools that are really basically sort of not really following the protocols, maybe, or basically, calling and asking the family to pick up their child, whereas this is the family whose mother and father are maybe daily wage laborers, and they can't afford to miss a day if at work, and if they have to leave work, come pick up their child, then that of course indirectly affects their functioning at home. So I think the school, if the school handles seizures and the epilepsy itself slightly in a better way, I think the problems of the mental health issues would also come down. Just quickly give you an example. I had a patient who was undocumented and uninsured, and if the child had a seizure in school, so they would call 911. The child had to be taken, just for a 30-second seizure, taken to the hospital. Now, this family was undocumented, uninsured, which means that when they go to the hospital, they already are struggling with getting, medicines because they are undocumented, uninsured. They are struggling to get emergency medicine for the child because they are undocumented, uninsured. Now they have to foot an emergency room bill because the school keeps calling every week and, sends the child to the emergency room and the child has seizure, when the child could easily be managed in school with proper instructions from the patient's doctor. So I think that kind of behavior from the school adds to the stress, and I think it really basically makes all of these domains really a challenge, because if the school were to manage the child's epilepsy properly, I think, in my opinion, that would also sort of help indirectly in with these behavioral health outcomes.
Oh, thank you so much, Sonal, for that, and thanks for providing that important anecdote. Pam, Chris, any other comments or questions here for this particular paper?
I
Pam?
just wanted to make a brief comment / plea as we highlight the importance of shared ways that we document our outcomes. And especially, I know Chris is going to speak of the common data elements, and I think PER can really be a leader. I know I run into trouble when we are trying to compare the assessments of neurodevelopment in children across different institutions. Are using the Violin, the Bailey, what's going on. And I think it would be great as part of the future directions that we would maybe at least agree within PERC institutions to say, if we're doing research in health disparities, or anyone that's participating, do we agree that just to give any random examples, like the Vanderbilt will assess ADHD, or we will use like CARS-2 for autism evaluations when we're conducting this type of research, just because it is very hard when you're doing this type of work. And I can't even imagine the hours that were spent by this group just sorting through all of this, and then even trying to compare different outcomes that are screening different things. And so, while I have a large audience, hopefully if people listening and our PERC colleagues, I think that would be great direction for the future, that we can, start agreeing more and more. And, the common data elements direction is a great start.
Great points, Pam. Chris, anything to add right now?
The only thing I was going to add was that I think, at least particularly within the school districts that I've seen, or in the places I've worked, I also feel that because of the way that schools are financed in the US, the schools where the students who are often needing the most support for behavioral health have the least amount of funds. And to be able to support those kids. And so my patients who come from districts that tend to have lower median household incomes, their schools also receive less financing in general. And so all of the time, I think when I've tried to work with schools, and I see for the vast majority of my patients that there's good intentions. There's always an exception or two, but I would say the vast majority of time there's really good intentions, the schools that I've talked to, but they just don't have, they don't have an OT, they don't have an ABA person, they don't have the supports that they need. And so I think that really, as we think about these kids within the environments in which they're put, and think about how the outcomes that affect them out that are well beyond the four walls of the hospital, like their school environment. We all see how, or I've seen how kids who live in different places really have access to different care. And so I think it really speaks to what Dr. Bhatia was discussing in terms of working across sectors, and the importance of some of the work like the Epilepsy Foundation is doing, is working with schools, working with local departments, working with local EMTs, not just to ensure that appropriate seizure protocols are followed, which is hugely important. And I've certainly had patients of my own where being sent to the emergency room when it wasn't indicated by their seizure action plan contributed to family stress and child stress and all of those things. But, I think as much as we can collaborate across sectors with schools and ensure that our patients who are in districts that are underfunded still have access to those services in other ways, I think will be important.
No, thanks so much for that, Chris. And as you're all talking about this, and I know, of course, for the first two articles, we focused in the US. As somebody who comes from a developing country originally, I just wonder to what extent all of this is magnified, so to speak, in many of these other low to middle income countries. But we need to move on. And Chris, your entry into this discussion has been much heralded. And so we will start off with this third article, which was published in Pediatric Neurology in 2025, and looks at the issue of common data elements regarding the social determinants of health in pediatric epilepsy research. And Dr. Briscoe was an author here. And so, Chris, if you could kindly walk us through this one.
Yeah, absolutely. So this work was built off of the foundation that Dr. Bhatia had described, thinking about how can we do a better job, even knowing what the landscape is for our patients. And so understanding and looking at the scoping review that social determinants of health are often not being reported at all. So thinking about like language and immigration, for a paper that Dr. Garcia Sosa at Lurie Children's is spearheading, where we looked again at even from 2019 to present, kind of when the scoping review stopped looking. And in that paper, we've only found 2 new studies that even mentioned language or immigration status in the epilepsy literature. Sometimes it's just missing, as that wonderful scoping review that was very painstakingly done by my colleagues showed, but also as Dr. McDonnell and Dr. Bhatia were highlighting, the ways in which even when people are doing their best efforts to include social determinants of health in their studies, the ways that they're being reported are not standardized, and that makes it exceedingly hard to understand, particularly for rare epilepsy conditions, how social determinants of health impact epilepsy outcomes and where do we need to be focusing. We have a vast body of literature that shows that standardization really facilitates us to be able to identify and analyze health disparities. So this was our effort to start to think about how do we standardize these data elements across our different special interest groups in the Pediatric Epilepsy Research Consortium, which I keep on losing count because we keep on having more, which is really exciting. But I think last I heard there was 14. And so how do we get all of these people from 90 institutions and 14 different groups to agree on something, which is, as you guys know, no small feat. So we started out through using a methodology called concept mapping, which is a qualitative methodology that's used often in community engaged research to help understand what do the people in the group agree upon and where are going to be areas where we need to think about things more closely. So it's categorized into these 3 different stages. There's 7 stages depending on which article you look at, but essentially brainstorming individually, and then doing individual sorting and ranking, and then looking at those results and doing an interpretation session for contextually and finalizing the study findings, and looking at this, and specifically in concept mapping through some visual data analysis. So that's what we did. So we enrolled PERC members as participants in the study. So these are epilepsy doctors, researchers, people who are invested in epilepsy, who are invested in this organization. And 81 people participated, which is good. Typically, you want at least 5 to 10 people involved in each study, so that was a good level of participation. And then near 48 members participated in the sorting and ranking, which is like thinking about how important each element is, but also how feasible it is to collect. And then that generated through our software, which is that we used for this project, a hierarchical cluster analysis map, which generated these different categories of social determinants of health. And then we generated the proposed common data elements after the interpretation sessions, which were several sessions where our health equity special interest group met to interpret the different findings and come up with this preliminary CBE set. limitations of this methodology. So only 33% of PERC membership participated in the overall activities, meaning that there may be some people whose opinions that we didn't capture. In addition, the racial, ethnic, and socioeconomic diversity of our participants were limited, and so there was an overrepresentation of white non-Hispanic people, as well as people who are of higher socioeconomic potential or higher median income. We think that that's probably reflective of the overall group rather than being specific to this study, but we don't have PERC demographic data, and so therefore it was not possible to compare who participated in this study versus who is a PERC member. And then the last, which we were working to address, was that families and patients weren't, their opinions were not solicited in this initial phase of the study about what they think should be common data elements that we should be looking at. After all of that, we came up with this proposed common data elements list for incorporation into PERC studies. And this paper has this initial list, which we're currently working on refining. As you can see in table 2, there was, I'm bad with numbers, but probably 41 or 42, as I recall, proposed data elements that were included. And then they were each mapped on importance and then separately on ease. So something could be very easy to collect, but not as important, or very important, but not very easy. And most of the items in the proposed data element set were from that green box in the right top, which were rated as being both feasible to do and important.
No, very, very, to use your word, important work, Chris. I think my first question, if I may, for you is a before and after question. And so you've done all this great work to standardize things, but we still have studies that are published in the literature which people are reading all the time. So how does the absence of these wonderful standardized elements affect how we interpret existing studies? And what do you think, in terms of this great work you and your colleagues have done, what kind of new questions or interventions become possible once these are more widely adopted?
Yeah, I think you get to a very important topic, which we're currently working to address, which is adoption. So it's one thing for us to propose these as being incorporated. It's quite another for people to actually use them. I think where we have been successful in presenting this work to our colleagues and other special interest groups in PERC has been awareness or thinking about these, doing this in a standardized way. So for example, the PERC epilepsy surgery database and this sorts of things. But I think adoption gets to the next step in many ways that we've taken in the study, where we subsequently, after publishing this work, did focus groups with our colleagues in PERC, as well as individualized interviews with families of kids with epilepsy, as well as young adults with epilepsy and adolescents with epilepsy, to ask them both about feasibility, predominantly for the providers. And so looking at this list, what seems possible for you to do? What would you be willing to do? And what are some of the barriers and facilitators of those things? And then from a family perspective, looking at acceptability. If we're thinking about including things like gender identity or immigration status or other things in a de-identified database, is that something that's acceptable to epilepsy families or not? Which hasn't been previously studied, because certainly as we're thinking about wanting to improve disparities, we don't want to put families at risk or be doing things in a way that are adverse to the community that we're purporting to serve. After all of this, we've done the focus groups, we've nearly completed the in-depth interviews. We're going to going back to PERC in May with a new proposed list of common data elements to see if that revised list will be feasible for people to incorporate in studies. as well as acceptable to families. This is all a long way for me to say that, I think that this was this is all building blocks. And so this was our initial list, but we know that it continues to require refinement, both in terms of how we're thinking about it, how it's being shaped by the reality that's happening outside of the work that we're doing. And so what might have been acceptable to include in this set a year or 2 years ago might not be acceptable today. And so I think recognizing that reality and wanting to do a revised list has kind of been our next step.
No, absolutely. You have to start somewhere. And so this is a very, very important first step. So kudos to everyone. My other question I have for you, Chris, is, well, I used to have a healthcare system boss who used to always say, you can't manage what you don't measure. And so my question for you is, how should researchers and institutions navigate the ethical tension between measuring inequities and the responsibility to act on them, especially if the resources are not necessarily there?
I think it's a great question. I think, and it's one that we actually asked to our families as we're doing this work. So is it acceptable for researchers to ask you about different social determinants of health if at that institution there are not resources to address the things that come up? And so if we identify that you have housing instability, for example, if you're at risk of becoming homeless, but that center doesn't have a social worker that can help you navigate that, is that acceptable to families to be asked those things? So we're still in the process of data analysis of that. I would say our reactions have been mixed. And so more coming on that. And I don't want to, before finalizing the data analysis, opine too strongly about my particular opinion on it. What I will say is that I think as we measure things, it helps us know where to target our energy and effort. And so, for example, in the paper that's coming up, we found that race and ethnicity was really a determining factor in delays to referral for kids with spasms. And we're going to go over that paper in a moment. Versus when we looked at our same center at kids who have Dravet syndrome and genetic diagnosis, it was actually language that was a determining factor to delay genetic testing for children with Dravet syndrome rather than race and ethnicity. And so even within a single center, that the most salient social determinants of health can be different. And I think that should drive where can we be doing better. And as institutions gain that knowledge, both about how disparities are playing out on a national stage in very specific ways, it can also help us to understand where we can be doing better for kids who are from certain groups, but ultimately making a better system for all kids with epilepsy. Because as we address, in my opinion, as we address those gaps for the kids who are most vulnerable, we're also addressing the gaps for kids who maybe aren't from that demographic group, but still may fall into those holes.
I love it. You're stealing your own thunder. So
yeah, I know. I was like, I feel like I'm jumping ahead, but
so Sonal, Pam, any comments, additional questions? No? Oh, Sonal, go ahead, please.
I think you kind of covered it, but I think the initial discussions that we had when we were also talking about the CDE was just the adoption and then ultimately the implementation, right? So I think how will we bring the change? And I think that is something that is perhaps POR can give us the foundation and the data, but that is a little bit outside the scope of PORC in how that would bring a change. I think it has to be at various levels. The hospitals with which the PORC members are, as well as the state authorities and then the federal bodies. So I think that change will take a long time. And like Chris said, these are like all small blocks that we are building, but hoping that maybe even after we are gone, this work will continue and ultimately will translate into a betterment of these children who really, really need these resources.
Well, on that morbid thought of leaving before rather early, we'll move to the next one. Oh, thank you, Sonal. That's excellent. Thank you. Move to the next paper, which is a paper led by Dr. Briscoe, published in Epilepsia in 2024, and looks at the issue of delays to care in infantile epileptic spasm syndrome, focusing on racial and ethnic inequities. Chris, please do the honors.
Yeah, so this paper, I would say similar to the other one, came out of foundational work that had been done by other colleagues at PERC, where Fiona Balmer, Dr. Balmer out of Stanford, and my other colleagues in the Pediatric Epilepsy Research Consortium Infantile Spasm Special Interest Group had shown that kids whose have Black non-Hispanic parents, and kids who have public insurance are at higher risk of not getting standard of care for infantile spasms, even when they're at tertiary pediatric epilepsy centers in the US. And this is especially important for this type of epilepsy, because for this type of epilepsy, each week of delay to standard therapy is associated with worse long-term neurodevelopmental outcomes. And so it's a time-sensitive epilepsy, and to know that kids whose parents are Black and non-Hispanic and kids who have public insurance are at higher risk of not getting standard of care was disturbing. That led us to want to look at our center, because certainly if this was true at a national level, we wanted to understand how that was playing out here. And when I say here, I'm talking about in Boston, because we wanted to know if this is a problem in our institution, how can we fix it? And so we looked at the last 100 consecutive children who have been diagnosed with spasms at our center. This was 2019 to 2022 at the time. And then we looked at factors, both clinical, such as what the child's etiology was, as well as social determinants of health, like language, median household income, and race and ethnicity. And we looked at how those were related to treatment delays, but also if the children did receive a standard treatment course or not. And so I think I showed this on the next slide about these T1, T2, T3 delays, but these are all time points in the 3 delays model, where from when a child starts to have epileptic spasms, to when the parents bring them to a first provider, that can be a pediatrician, it can be an urgent care, it can be an emergency room, to when they receive a neurology consultation, subspecialist consultation, to when they get started on therapy. And so because there's all of these different steps in diagnosis, you can have delays anywhere along the line. And so if we want to go back to the previous one. And so we looked at each of these with regards to both our clinical and social determinants of health. And so for the T1 delays, race and ethnicity was associated in the univariate but not the multivariate model. For delays to referral, meaning the time from when a parent brings their child to a pediatrician or emergency room to when they get seen by a neurologist, that was significant in both our univariate and multivariate analysis, with an odds ratio of 5. And then our T3 delays were not related to race and ethnicity, larger distance from the hospital, and age at diagnosis was associated. And then a standard treatment course, at least for these 100 kids within statistical error, was not associated with any clinical or demographic factors at our institution. In terms of limitations of the study, I think one of our major limitations was that we grouped white non-Hispanic families and the families who we put into the category of Black, Indigenous, and people of color as binary groups. This was done because of when we looked to do this for different races and ethnicities separately, we were underpowered to do the analysis, and so we wouldn't have been able to do it. We wouldn't have been able to do the analysis otherwise, but I think is a significant limitation, as Dr. Bhatia pointed out earlier. And And then in the study, we did attempt to look at language, but only 11 patients out of these 100, their families used a language other than English. And so therefore, we were underpowered to really look at language as a social determinant of health in this cohort. So while we found that I think our major finding from the study was that for children who are from Black, Indigenous, and people of color, racial and ethnicity groups, they're more likely to have delayed referral to specialist evaluation, which means that they're not getting referred in a timely manner from when they're presenting to the first provider to when they're seeing a neurologist in the catchment area that came to our hospital. And this study drove a lot of subsequent work that we've done in order to try to address this inequity that we saw occurring.
Yeah, no, a very important study, and congratulations, Chris, on it. I think my first question has to do with, because you very eloquently spoke about how there's this moral imperative to address the inequities, and you taught us about the chain and everything. But I'm reminded about that show, Whose Line Is It Anyway? Whose responsibility is it anyway? Especially because of that finding that these inequities tend to arise before the families actually reach the specialty care.
It's a great question. I think, and for me, it's a shared moral responsibility in the medical community in a lot of ways. What we've done at our institution has been a couple pronged in order to try to at least take on our part of that burden. One is that we've done a lot of outreach to local pediatricians, and we have a fast track essentially to neurology evaluation for any infant where the pediatrician identifies abnormal movements that could be concerning for spasms. Even if there's a low suspicion, those children get an EEG within a week and then get seen by us within a week or two, depending on what their EEG shows. So if they have a normal awake and asleep EEG, usually within 2 weeks, we'll still see them. But obviously, if they have an abnormal EEG, then we address it immediately. And so we've made this fast track program, which our wonderful nurse practitioner who works with us, Candice Marty, is currently looking at that data to see what impact that has had. But certainly trying to do our part in assuring that when pediatricians are trying to get these kids in, that we're not that it's not the non-urgent slot in 3 months that results in these kids having delayed diagnosis. We've also done a lot of educational outreach. We made an open pediatrics module for pediatricians, which is free online, about spasms identification, and have done a lot of community pediatrician center presentations and education about spasms to try to do our part. But I really think that the moral burden is on everyone who comes in contact with one of these children. And as a pediatric epileptologist, it's my job to make sure that people with whom I'm able to interface have at least access to knowledge about this, and then the means to address it if they are able to and motivated.
Absolutely. And Chris, in your mind, what could be the plausible mechanisms by which structural discrimination might contribute at the early diagnostic stage in pediatric epilepsy?
We've done, after this, our next step was to do in-depth interviews with families, with caregivers from historically marginalized groups, to understand what the drivers were and where the structural inequities and the structural discrimination was showing up. In that, we found that it's obviously multifaceted, but communication was one of the primary drivers, in that families from historically marginalized group consistently told us that either they didn't feel that their provider was listening to them, and so the ways that they were trying to communicate their concerns clearly weren't getting through or weren't being, as the families put in their words, to being taken seriously. And then I think that the other major communication related aspect that families brought up was the perceived hierarchy and their ability to push back against providers when they do not agree. And so, for example, one of our participants who identifies as Black and was a father of a child with spasms told us that he was very reticent to push back against his primary care provider when they were concerned, because he was worried about this perception of him being perceived as an angry Black man, and then how that might break down the trust relationship with the pediatrician. And so, I think it's on us as providers to realize that even though we may be perceiving that we're providing the same care to families from different groups, and including historically marginalized groups in our mind, that we also have to be aware of these structural historic dynamics where our patients who are coming from different backgrounds may be more or less able or feel more or less empowered to advocate with us in the same clinical scenario, where, like, I might say, I'm not really worried about these movements. And a family who's not from a historically marginalized background may feel empowered to say to me, okay, that's nice, you're not worried, but I'm really worried. How can we be sure things are okay? A patient who is from a group that historically hasn't been listened to physicians may not be able to push back in that same way, or may fear the repercussions of doing so.
Yeah, no, very well said. Sonal, Pam, additional thoughts? Sonal?
Two things. I think one is the topic of education, and I think that is very important. Last year at AES, we presented an abstract where we looked at, where we showed pediatricians videos of infantile spasms and non-infantile spasms, and basically looked at how comfortable they were in identifying infantile spasms and then following the next steps. So infantile spasms is a medical urgency, and how did they perceive the next steps. So, and we did find that even from academic medical centers, that there were certain providers that just didn't know what infantile spasms are, or if they knew what infantile spasms were, they didn't know what are the next steps. Like, the child should not be waiting for a month to see a neurologist, the child should go to the emergency room. So I think that kind of brings us back to really the way the residency is structured for general pediatricians here, and how neurology has become an elective for them, whereas maybe putting that into a mandatory rotation would kind of allow us to give them education as they are training, and not after they have been in practice, because old habits die hard. And sometimes when you are in practice, you may be so busy and things like that you may just be really not wanting to change your ways. So I think that's sort of one way of really addressing this gap from a practical standpoint. And the second of all, I think Chris brought up this great point of how certain communities perceive that the provider might look at them differently, is this concept of the implicit bias that we all have as providers. And I think, again, I think plenty of work has been done to showcase that. But then when it comes to us as providers getting training to help mitigate that, I think that training is also necessary, and right from a medical school and residency. And especially for people like you and me who are not from the United States, we may not have these problems in our home country, but when we come here for education and training and practice, I think this should also be a part of training, so that we also become culturally sensitive, to people that are belonging to the different cultural, race and ethnic groups here in the US.
Great points.
Yeah, and I wanted to highlight the importance of really just having protocols. I often, as a native Spanish speaker, take care of many patients that have been seen by other providers in my division as transfers of care. And it's the first time they might tell me many, many, many things. And if there are other providers in other specialties are also not Spanish speaking, then I get all of it, the G-tube, the feeding, the constipation. And often those providers thought they had explained everything and they had done everything. And it was just that, they have an interpreter, things are taking long, their children are not tolerating the appointment, how long they've been there or waited. And so I think it's very easy if we don't have protocols for certain issues, particularly things like spasms or other things that are more urgent, we may gloss over, things that could be easily taken care of or at least assessed quickly. And so I'm happy to see this type of work being done. I know in my institution, we are working on that as well. And hopefully we can hear more and more and just standardize things, because that's really the best way to avoid our implicit bias that we are all going to have. And even when you are aware of it and you do the trainings, it's still present. And I think using standardized pathways and things that everyone can just kind of follow are really going to be the best way. And, there are pathways. So you also want to be able to use your brain too, of course. But just having at least some guidance so that we can all start somewhere is very important.
And Dr. McDonnell, the other thing I wanted to highlight from what you just said that I was maybe implied, but you didn't directly say, is I think it shows the importance of having people in different groups and from diverse groups in medicine so that families can see themselves represented. And the importance of having people who are native Spanish speakers, who have that background, who come from different racial and ethnic groups, make our system so much stronger and really provide really good care for our patients and really important care.
And I couldn't agree with all of that more. I mean, as you were all speaking, I just wondered, as many of you might know, the issue of these trust clinics. Some institutions are increasingly having these trust clinics, and they're not necessarily staffed only by providers of a certain group, but also providers of even a majority group who are culturally sensitive and are trained and everything, just to try and make patients feel more comfortable in interacting with their providers. And as you're all talking again, being an adult neurologist, I just wonder how it is for some of these marginalized populations. It's one thing to have those kind of that sense of apprehension and those perceptions for yourself. I'm sure it's even more compounded when it's your child as well. So I continue to learn from all of you as to how you navigate that issue. So thank you. Yep. All right, we're going to go to our fifth article, which was published in Epilepsia Open in 2025 and focused on the issue of disparities in utilization of genetic testing for non-acquired infantile epileptic spasm syndrome at a single center in North Carolina. And Dr. McDonnell is going to kindly guide us through this one.
Thank you. Thank you so much for inviting me and bringing me in such good company. This particular study is, much more focused. So it was interesting for me to read about what they were doing in the single center. But as, most of people listening probably know, infantile epileptic spasm syndrome is a severe early onset epilepsy that is characterized by epileptic spasms and developmental regression. That name has had many iterations through the years, but that's what we are settled on. And they were very interested in looking at how genetic sequencing was being done and what demographic and clinical factors influence the utilization of this tool, given that we know delays in diagnosis and management are linked to poor developmental outcomes. That's very well documented. And, the use now of genetic testing has really, we're not quite as like precision therapy for everyone, but certainly it can at least end a diagnostic odyssey, which is hugely important. It can avoid, our patients getting lumbar punctures or extra sedation and repeating MRIs. If we really know, just as a few examples, if we know why someone has something, of course, now we do have some specific ways to treat spasms. If you have tuberous sclerosis, we know, right, we're going to vigabatrin first. And so genetic testing really is becoming very important, not just to know, and now also in diagnosis, and it is essentially recommended as part of any evaluation. So in this particular study, what they did is that they did a retrospective cross-sectional cohort study of 421 children that were diagnosed with IESS. That's what I'll call it for the rest of the chat, between 2015 and 2021 at one single healthcare system. And they looked at the primary outcome, which was association between the utilization of genetic sequencing and demographic factors. I will say what they did was they looked at the children that were diagnosed with IESS, but if they had sort of a known cause for it, they excluded them. So things like IVH or trauma or things like that. The secondary outcomes they looked at were utilization of genetic sequencing and its association with healthcare providers or clinical characteristics. So they found after they ended up looking at 121 children after they reviewed those 421. And then they found that 74 patients had genetic testing performed, and they did find that race had significance in testing. So if you were white, you were more likely to get tested. And they also specifically found that non-Hispanic, Black, African American children had a significantly lower odds of undergoing genetic testing. Just to go through some of the characteristics they recorded, sex assigned at birth, they looked at race, which I think seems to be a common theme here, but it was white, Black, African American, and other, or prefer not to answer. We could probably spend a whole hour or a whole day talking about how we classify and how we divide race and ethnicity in our studies as being like a big problem as well. But they also looked at ethnicity, so Hispanic or not Hispanic, and whether they answered or not, language, English prefer or not, rurality, which was nice because that's not always necessarily included in many studies, and then insurance, whether it was public or private or uninsured, provider setting, academic or not, and whether the provider was a physician or advanced practice provider, and whether the providers were neurologists or not. And then in that particular listing, unless I said what the race was the only thing that was significant, and then they did logistic regression models, and the only thing that they found that was significant there was non-Hispanic, Black, / African American. They didn't find any other significant associations between language, rurality, or insurance status, and the utilization of genetic sequencing, which was surprising to me. I know language is something that has been looked at a lot and shown some differences. They did comment that there was a low number of patients from small towns and rural areas, which wasn't necessarily representative of the state of North Carolina, where this single center was located. And they did see with their secondary outcomes that more severe seizures and additional interventions besides standard treatment were associated with higher rates of genetic testing. So essentially sicker patients, I guess, makes sense that people would want to look more to see why they weren't responding to treatments. And so I think for me, some limitations here is that they excluded acquired causes, which I think would have left patient outs that would benefit from genetic testing. So I think that is very important to look at. So now we know, for example, if you have a pathogenic variant in COL4A1, you're more likely to have IVH. This one I think gets tested more. I'm making some assumptions here, but even tuberous sclerosis, if you have a structural, if they think you have a tumor, and then that may be a structural reason that they would not test. So I think that's something that I would still want to look at. They do mention that they may have been underpowered to detect certain disparities, particularly rurality. And I think, again, with the language, I was a little bit surprised, and it did not seem like they were underpowered there, and that the percentages of the patients that spoke another language were similar to what they looked at from the census data from their state. So I'd be curious to look into that a little bit more. And then, of course, that's always a limitation when it's a single setting only, because you, of course, cannot necessarily apply that to everywhere. They concluded that the findings of the study highlight the need for evidence-based solutions addressing genetic sequencing utilization that may disproportionately impact children from medically underserved groups. I certainly agree with this. I think that just starting to look at the data, even if it doesn't apply everywhere or if it can, be refined, I think it's still important to start looking somewhere. And then that can point you to your next steps. And so the implications here, as we all know, I think early genetic sequencing can lead to more timely and personal treatment interventions, potentially allowing the use of targeted therapies that address the underlying genetic cause. And delays or lack of proper evaluation can continue to deepen the disparities that already exist in many of these medically underserved groups, and particularly in spasms, as we know that time to treatment really, really matters. And I think, this was table 2. The first table looked at the demographic factors, and then I just added this one where they were showing that the non-Hispanic Black were less likely to get tested, and then if you were seen by a neurologist, you were more likely to have genetic testing ordered.
Well, that's super, and thank you so much for that, Pam. To your mind, and you touched on this, and it sounds like the authors did as well, what could be some additional avenues to create evidence-based solutions to decrease these genetic sequencing disparities in underserved groups? And I know, of course, in this case, they were underpart in terms of rurality, but just your thoughts.
I think that's a great question. And just going back to what I was saying earlier, which is if you standardized your methods, then, and here in speaking about what we do in clinic, I think then you're less likely to say, oh, this person had IVH, they don't need to be referred for genetic testing. And so what we have done in our institution that I really like, and that has been done in other places as well through the epilepsy learning health systems, where we have templates for our epilepsy taking history. And as part of those templates, you kind of go down a whole list where you talk about what seizures patients have, you classify those seizures, but then there's sections about essentially the type of care that everyone should be getting. So when was the last time you had a seizure? When you went to the hospital, the ER, when was the last time rescue med was given? Is that patient, if they're age appropriate, taking folic acid? Are they considered drug resistant? If they are, have they been referred? What other things? And so that's something that every person has access to if they choose to use it. As Chris mentioned earlier, having this elements doesn't mean that everyone is going to adopt them, but a majority of us do, and we work hard to get people to do it. But as you click through all those things, there are reminders that you have, whether you remember to offer folic acid to 14-year-old female taking an anti-seizure medication. Same thing when you're going down, are they drug resistant? Have they been referred for surgical pathways? Have they been referred for genetic testing? And there are certain it's a fast pass where you can click off all the orders, including neurogenetic referrals. And so I think that is really one way to kind of get everyone on the same page. And then we're all also, it's good for research because then you can kind of pull these elements to as you're going back and looking to see who's being referred and who isn't.
Absolutely. No, that's terrific. And my other question is, would it be worthwhile to look at genetic testing done in patients that present with structural causes of IESS?
Yeah, I think so. I think we're learning more and more. Also, something I didn't mention, but mimickers of HIE, mimickers of torch infection. So, hypoxic ischemic injury at birth, or patients that appear to have had, torch calcifications in their brain. We now know they are those genetic mimickers. And so, unless in my practice, HIE, IVH, it all gets referred, unless you were in a car accident and then you had a direct brain injury from that. I think in general I refer almost everyone. I think that also just reflects access to care. I realize that not even every country, but even any state may have the access. Fortunately in Pennsylvania, we're very lucky that all children can qualify for medical assistance if they have epilepsy as a diagnosis without, income is not important. And our secondary insurance guarantees not guarantees, but you can get genetic testing covered, which I have learned from meetings at AES. That is not the case in other states. So I realize that I have a lot of privilege in my practice with that. But, right now we do try to test as many children as we can. And I hope that other folks will work on doing that as able within their abilities and resources they have.
Thanks, Pam. So now, Chris, any additional thoughts?
I was just going to share one paper that had an answer to this question about how common are genetic etiologies in structural epilepsies. And this was looking at patients who had abnormal brain imaging. And so I think, long story short, that you're allowed to have structural abnormalities and including acquired, so like Col4A1 and those sorts of things, and have a genetic cause.
Thanks, Chris. So now?
Thank you.
I just had a question on this paper for you, Dr. McDonnell. You mentioned earlier that they had looked at whether the patient saw an MD versus a mid-level provider.
Mm-hmm. Yeah.
Did they have any analysis of that data? Did it show anything statistically significant?
Yeah, so they looked at whether they were seen by physician or advanced practice provider, and that one was not. Their p-value was 0.078. They only got significance when they looked at whether the provider was within neurology or not.
Thank you. Great discussion.
I had one quick
Of course,
follow-up
please.
question for Dr. McDonnell. Sorry to be annoying.
No.
I was curious. You had mentioned that you were surprised that language was not as significant to such a determinant of health. I was wondering if you could talk a little bit about your experience or what some preliminary data has been at your center that might be a little bit different.
Yeah, so I haven't specifically looked at language in infantile spasms, but just as a background on me, I run a Spanish clinic at my institution, and we are now working on looking at those outcomes, including genetic testing and other areas, but mainly in all our patients with epilepsy, not necessarily divided by what type of seizures or whether genetic or not. And just in writing up many, abstracts and posters and things, looking at the literature, there has been a lot of data out there as particularly I'm looking at Spanish as first language or preferred language, where that is a significant barrier to care, just, across the board, not necessarily just for spasms. And so that was, I guess, surprising finding to me. And I think it was surprising to them. And they had even mentioned a specific study that had documented that. I think it's the ASSIST study that one actually specifically looks at infantile spasms. I think ASSIST stands for Assess Symptoms and Specialists in Infantile Spasm Treatment. And that particular study showed that non-English preferred language experience significant delays in care compared to English-speaking counterparts. So there's data out there specifically for spasms. And then in my own experience, starting to look at some data and just preliminary sort of background data already, there are a lot of disparities already that exist. So, curious why that wasn't the case here, but, maybe that's a sign that things are changing. So
Hopefully. All right, great, thank you. We'll move to the next and last article, which was published in Epilepsy Currents and looks at building bridges for equity in epilepsy care. Dr. McDonnell, please.
Thank you. Yeah, this article I thought was very interesting. It's not looking at a specific research study, but really maybe talking about solutions, which I really love. And so the background here, as we've been talking about for the last hour or so, is that there are many well-documented health inequities in epilepsy care for minoritized groups across the US and the world. And I do like that word, minoritized groups. I think, and if you're from another country, I think, if you're from South America, whatever country you're from, you're not called Hispanic there, right? I'm not sure, I'm not that familiar with research out of African countries, but again, we're looking at just different backgrounds and things. And so I think it's so important when we look at the groups, it's like we make them minorities here, but in other countries it's different. And so I think it's a good lens. And I also really like that they are looking both in the US, but also across the world, because the needs and the differences are just very different. And so there is an urgent need in general to recognize the gaps in care and advocate for patients to achieve equity. And I have Dr. Bhatia here, who was part of this group, so hopefully she can also comment on some more insights at the end. But the members of the Health Disparity Special Interest Group had a session at the American Epilepsy Society annual meeting to discuss known health disparities in pediatric and adult epilepsy and proposed ideas to work together to improve healthcare for all. So again, not just documenting disparities over and over, but like, what can we do about it, which I find great. So as we all know, they discussed that disparities in epilepsy care remain prevalent, and they talked about potential solutions, including utilizing a useful framework for studying determinants of inequities and neurological disease, with the goal of developing research programs and policies that are long-term, impactful, and sustainable. And I think this is sort of the theme of what we've been talking about here all night, right? Like frameworks, things that could be reproduced, things that we can all be using together. And it is imperative to prioritize actions that will address the burden of epilepsy globally such as educating clinicians, caring for these patients. The limitations I thought for this particular conversation was that only a few institutions and countries were represented in the discussion, but I love that the discussion is being had. They concluded that health disparities in epilepsy care remain a global challenge affecting minoritized communities in the United States and individuals in low-resource countries disproportionately, and that nationally efforts must include frameworks that address social determinants of health, and globally initiatives should focus on education and collaboration. And so the specific examples they talked about, which I thought was great, I know in Chicago they talked about a Spanish clinic, which is something that I'm doing at my institution. And then nationally, they talk about a particular program that's called the Epilepsy Assessment and Management course. That is a training that covers 19 topics over a period of 3 months. It's virtual. There was no cost. So just also talking about educating our colleagues and, providing free education by experts that may not be available worldwide. I think that's fantastic. And so the implications here is that there is much work to be done, and ultimately achieving equity in epilepsy care will require commitment from all stakeholders. So anyway, very interesting paper to read, and, hopefully I'll get to be part of these conversations in future groups.
No, thank you for walking us through that, Pam. I enjoyed the paper as well, and I learned quite a bit from it. I love the fact that it looked globally. I love the fact that it looked at both pediatrics and adult. And I loved the fact, as you alluded to, that it focused on solutions and best practices as well. I sometimes have been wary over the years of just admiring the problem without actually, trying to tackle it. So I really enjoyed it. It gave me a lot of hope, gave me new ideas and everything. And speaking of ideas, and what I've loved about what you've all done during this session is to incorporate your own real life, real world scenarios and examples. And so, Pam, if you don't mind, are there any specific examples at your institution that can address some of the gaps in care that were mentioned in the article?
Yeah, so as I briefly said, I have my own Spanish clinic in neurology that was started in 2021, and every year it grows, and it's been such a pleasure to start. But then other things that we are doing at our institution that I'm very proud of is that we have pathways you can really Google. I'm sure other institutions have these, but very well sort of researched, evidence-based pathways that are free and available, so that if you're a resident in the middle of anywhere at 2 a.m. and you don't know what to do with like a febrile seizure, you can get on there, and this is like standardized, and it will run you through every step. And that's available not just for neurology or epilepsy, but really for most of like the common childhood diseases and things that anyone can do, and that's available free for everyone. We also have modules that are available for free, and also I have the pleasure to both travel and do virtual talks for many different countries around the world. I usually do Middle East, and then for Latin America and Spanish. And these are all free, of course. And so like just training med students, residents, and general pediatricians. And so that is something that I think we can all contribute to, getting on a Zoom, giving a talk, even in English, that other residents, med students, or even, neurologists or pediatric specialists in other countries can really not only just see once, but also like go back to if questions come up. Is something that we can all be doing. And that's something that we are doing at our institution very frequently. And it's very encouraged and supported within our division. So I encourage hopefully other places to do the same.
Well said, well said. Perhaps I can ask Sonal and Chris if they have any other thoughts about this. Sonal?
Well, I don't have any other thoughts at this time. I think Dr. McDonnell covered everything that was to be said.
Oh, wow, that's a ringing endorsement if I've heard one.
Almost felt like I was in the room. I was listening.
Chris, any thoughts, or are you good?
Unique opportunity that we got to actually put into writing the findings of a session at the AES, which I think, I don't think I've seen that happen very often, but I think more and more recently I've seen some come across. But that was great, because we all had our little talks, and then we kind of compiled it into a paper and a publication, which was kind of pretty cool, I thought.
Well, kudos to all of you and kudos to the AES for doing that, because you're right. I mean, it's one thing to just talk the science and nothing to walk through and translate it into something that's disseminated for all of us to learn from and be inspired by. So that's great. Chris, did you have anything or?
No, I just wanted to thank you for getting to be a part of this conversation and to getting to hear Dr. McDonnell's, Dr. Bhathia's thoughts as well.
Yeah, no, thank you, thank you, thank you. And speaking of thank yous, I just want to express my profound appreciation to Dr. Bhatia, to Dr. McDonnell, and to Dr. Briscoe for taking the time and trouble to share their expertise and insights on these very important articles. Really, really appreciate it. This was supposed to be an hour, but as you can tell, we all enjoyed this and it's gone well over. But I hope you'll all find that it was worth your while. It certainly was for me. And I'll probably watch this a few more times to gain even further insights. So I just want to thank all of you for doing this. I also want to put a plug in for SEQUINS as well. We have our upcoming conference on May the 14th. 2026 in Dr. Bhatia's old stomping grounds in Charleston, South Carolina. So please join us. It's a hybrid conference and we are accepting abstract submissions now. We also have our journal, Equity Neuroscience. Please feel free to submit or review papers for us. And then we also have a podcast as well, which is monthly and focuses on very important issues in equity in brain health. And so thank you all so much and wish you a happy new year in this first month of the year. Thank you.
Thank you.